EuroMAC, a European registry for McArdle's disease.
Thank you very much. Thank you very much for inviting me to this meeting. It's a real pleasure to be here, and I'm very grateful to the organisers for giving me an opportunity to talk about EuroMAC, and also later on an opportunity to talk about Translarna or Ataluren for Duchenne muscular dystrophy. EuroMAC is a network that has recently been funded by the European Union to establish a registry for people with McArdle disease and other rare glycolytic disorders. And I think you heard just one slide about McArdle disease this morning on the talk about muscle biopsies. I thought what I'd do is just talk a little bit about McArdle disease, because that's the most common of the glycolytic muscle disorders. And then in my last two slides, just tell you a little bit more about the registry. And I think to give you the background, I think it's important to be aware, I'm sure you are already, of the three types of metabolic, if you like, processing that goes on in muscle tissue for energy. That is, we have three substrates. We use the phosphagen pathway, and we have about 10 seconds of stored energy as ATP. We use the glycogen pathway for strenuous exercise and for when we first set off doing exercise, so for the first few minutes. And then we use fatty acid oxidation for when we're resting or when we're doing more prolonged exercise. And so if you think about that, it's then fairly easy to identify patients when they present with rhabdomyolysis with different metabolic conditions. And we can also think about using the phosphagen pathway, the short-acting pathway, to help patients when they can't use glycolysis. So patients with McArdle disease and other glycolytic disorders, I'm sorry I don't have a pointer, so I don't know if you can see it, have symptoms immediately within 3 minutes of starting an activity, or when they're doing isometric activity or very strenuous activity. And as muscle blood flow increases to the muscles, within about 8 to 10 minutes, people with McArdle disease will get a second wind, and this is pathognomonic for the condition. And this will help you identify patients when you take a history. And I run a national service in the UK for people with McArdle disease and other related disorders, and it's by far the most common cause, genetic cause of rhabdomyolysis that we see. So we have about 150 patients attending our clinic, compared with only 5 patients with Tarui disease, 1 patient with GSD13, and a smaller number with GSD9. So it's by far the most common condition. And the incidence is somewhere between 1 in 100,000 and 1 in 167,000. But I suspect it's closer to 1 in 100,000 because many of the patients we see don't get diagnosed until quite late. They almost all have a raised CK, and the majority of patients have a CK that's around 2,500 to 5,000 units. The lowest we've seen is just above the normal value at about 200, but that's quite rare. And in a routine clinic setting, it's rare to get it above 10,000 unless a patient's had a muscle contracture. And as you saw this morning, the muscle biopsy shows these subsarcolemmal blebs of glycogen and complete absence of the enzyme phosphorylase. So this would be a normal biopsy here. In the UK, we're quite fortunate. We very rarely do muscle biopsies now because we can diagnose about 80% of patients just looking for 2 specific hotspots in the muscle phosphorylase gene. And these are what we call the R50X in exon 1 and the G205S. So they're very easy to pick up. And then if we don't pick up those mutations, we go on to full gene sequencing. And as I mentioned, many of our patients are diagnosed quite late. They almost all have symptoms from early childhood, as long as they can remember. But very rare for patients to be diagnosed below the age of 30, even though they've been to see medical practitioners. And we still see patients being diagnosed in their 50s and 60s, and it's usually when they're put on a statin. And it's not because the statin has made them worse, it's just because it's unmasked the muscle cramps and the high CK. So every patient gives a history of exercise-related muscle pain and fatigue. They will also give a history of a second wind if you ask for it. But actually, myoglobinuria is less common, and only about 60% of our patients will have ever had an episode of myoglobinuria. And yet all of our patients are terrified of acute rhabdomyolysis and renal failure, but in fact, only 10% of ours have ever had a bad episode. Other features, they may have muscle hypertrophy, and in older patients we see muscle wasting and muscle weakness, but particularly involving the upper limbs and the paraspinal muscles and the trunk muscles. Very rare to get lower limb muscle weakness. The other cardinal feature is a muscle contracture. This is where the muscle seizes and the patient can't move it. It becomes swollen, and that's when they develop acute rhabdomyolysis. And this is brought on by strenuous activity, such as patients sprinting or running, lifting or carrying heavy things, but also opening jars. And sometimes when the hand goes into a contracture, that can be mistaken for myotonia. The other thing they can't do is crouch or squat. And we've seen a couple of patients who've, when they've been to see a neurologist undiagnosed, asked to do 10 squats or 10 crouches and have ended up going into a contracture. And what I think is not recognised is when people get pain for other reasons, or if they're tense or emotionally charged, they'll get a contracture then. So we had 2 patients who did the usual when their football team scored a goal and they cheered, and they both put their CKs up to over 60,000. So that sort of muscle isometric contraction can cause rhabdomyolysis in these people. And we see also some atypical patients. I think they're always interesting in a rare condition. So we have one patient who has no anti-gravity power of his biceps, and we don't know why. But all of his other muscle strength is normal. We have another patient with progressive muscle weakness with a rimmed vacuolar myopathy, and I noticed there's been another patient reported in the literature. We've got 3 patients who've had severe focal shoulder wasting following injury. And we've got 4 patients with really quite severe axial and shoulder girdle weakness. And finally, I've not seen a patient with this, but it's reported in the literature, patients with splice site mutations that mean they produce small amounts of the functioning enzyme. So these patients produce about 3% of functioning enzyme, but have much milder symptoms. So this is where we see the muscle wasting, particularly around the paraspinal muscles. There may be scapular winging, and also around triceps. And this is a patient with much more severe paraspinal muscular atrophy, and actually he's got quite a waddling gait. And these people can look like they have a limb girdle muscular dystrophy. And we see a lot of sequelae. This is not a benign condition, or not as benign as it's reported to be. We see a lot of psychosocial problems in people with McArdle disease, and they really report distressing childhood experiences. So we see a lot of non-exercise related pain and fatigue, a lot of depression and anxiety and other psychiatric disorders. And we have quite a high rate of people who are obese, and we have one patient in particular, only 32, morbidly obese, already had a stroke, already got hypercholesterolemia, diabetes, and diabetic retinopathy. And in fact, when we looked at our whole cohort of patients, this is this table here, this column here are the non-McArdle adult population in the UK, and this is our McArdle population. We have increased incidence of type 2 diabetes, but actually quite a high incidence of ischemic heart disease. And I think this is probably secondary to sedentary lifestyle. So we heard a lot about exercise this morning and how important it is. If you can't exercise, it has really quite significant effects on your health. And finally, we see an increased incidence in gout in these patients, and also in our patients with Tarui disease. From what we can tell, pregnancy and childbirth are not a risk to women with myocardial disease. And in fact, most of the women we speak to say that their symptoms were actually a little bit better during pregnancy, which is quite interesting. But nobody has had myoglobinuria following, during or after delivery. So we have a multidisciplinary team, and we use several approaches to treatment. Firstly is to train patients to how to best use the second wind, and that involves a pacing strategy. We try and prevent rhabdomyolysis by giving the right advice to our patients. There isn't any specific dietary advice at the moment, but we do try and make sure that they're not obese, because carrying extra weight makes it harder for them to get around. And now we're actually working with a cardiologist to try and monitor and prevent some of these cardiac comorbidities. And we have in our team a clinical psychologist, and actually he's one of the busiest members of our team. And we do a simple evaluation in our clinic, a 12-minute walk test, which I have to say is diagnostic, and you don't need any equipment other than a corridor that you can mark. And we ask the patient to walk as far as they can in 12 minutes. But we also use a Borg rating of perceived pain. And we ask the patient not to let their pain exceed level 3. And this is to make sure they don't induce a contracture. And then we measure their heart rate every minute and their total distance travelled. And if you look at the results here, these are from a 16-year-old boy. And what you can see, at 1 minute, his heart rate is 90 beats per minute and he has no pain. But as he develops pain, quite severe pain, at 3 minutes, there's a big jump in his heart rate. He slows down, he carries on walking at a slower speed, and then here, at 9 minutes, his heart rate suddenly falls, and that's the start of the second wind, and he can start to walk faster. And if you plot that change, the heart rate against perceived pain, you can see very clearly what happens to a patient with myocardial disease when they set off walking. And you can see the onset of the second wind when they can carry on then walking without too much difficulty. This is Andrew Wakelin, who was previously the president of the Association for Glycogen Storage Disorders in the UK, but he's also one of our EuroMAC network members. He's a patient advocate. He has the condition himself, but he's produced some really useful information for patients, and these are available in different languages, and he's very happy to support other countries with these useful pieces of information. And Andrew himself is so well conditioned from exercising that he took 3 patients on a trip through the Dolomites last summer. So that was really surprising. Because exercise actually is the best treatment for people with myocardial disease. So regular aerobic exercise conditions the muscles for fatty acid oxidation, and it improves the efficiency of the second wind, and it makes life easier for people with a condition. So we recommend regular aerobic exercise. And our clinic has been running just since 2011. And if you look at our 12-minute walk test, we have probably 4 groups of patients, actually. We have what we call our elite athletes who achieve over 1,000 meters, so they're almost at normal. But we have really severely impaired patients who walk maybe 200-300 meters in 12 minutes. And with regular exercise, you see a gradual increase in the walk distance that they're able to do. And with each individual patient, our average has been an increase of about 117 meters in that 12-minute walk test, just over a 12-month period of doing extra exercise. We also know that quality of life is significantly impaired in these people. It's well below normal, but again, on follow-up, with patients who do regular aerobic exercise, we see a statistically significant improvement in their quality of life scores. So just to finish the last few slides, there are a number of other glycolytic conditions that are much rarer. You've heard about Pompe disease, which we don't manage, but we're interested in these other conditions, Tarui disease, PFK deficiency, and then these other very, very rare distal glycolytic disorders. And these are quite difficult to diagnose, but with next generation sequencing, I think we're going to see more of these patients. And in fact, we've just diagnosed our first patient with beta-enolase deficiency, which is down here in the pathway. And this patient, interestingly, is much milder than our people with McArdle. And interestingly, the patients with Tarui disease are much more severe. So just to finish on the last two slides, as I've mentioned, this registry is for all of those rare glycolytic disorders. We want to try and improve diagnosis, but we also want to try and identify patients for several reasons. One is so that we can actually understand the real natural history of these conditions. Secondly, we want to improve diagnosis and improve management, particularly standards of care. And finally, we'll have a registry for international clinical trials, because if you look at all the trials for McArdle disease, the biggest cohort contained only 22 patients. Please have a look at the EuroMac registry. I've put some leaflets on your desk, and on that registry there is a video that you can have a look at, which I hope will be helpful to you. And also we're planning a training session, a webinar session in November of this year. So if you'd like to join that, it's free. You can email Xavier Ortega here, who is our network coordinator. So I'll just leave that slide up for a moment. And then finally, I'm just going to, just to summarize, really, that McArdle disease, I think, is more common than we recognize. I think there probably are atypical presentations, and we've got something to learn from those patients. These people have quite a debilitating condition. They need multidisciplinary approach to care, and we need to start looking at these other comorbidities. Treatment is exercise, which is paradoxical. And please have a look at the EuroMac registry. And these are our EuroMac colleagues here. And I haven't listed all the names because there are too many of them. And this is my team in London. So thank you very much.